Right. Good morning, everybody. We're going to get started with our webinar today. Welcome. My name is Amy Forbes. I'm the training manager at the Northwest Mental Health Technology Transfer Center, otherwise known as MHTTC. Welcome to today's webinar titled A Biopsychosocial Model for Chronic Pain and Strategies to Support the Sensory and Emotional Experience of Those Living with Pain. Today's webinar is presented by Kaitlin Touza, Bethany Pester, Eric Wanzel, and Elizabeth Paulson. Before we get started, I'm going to go through and give you a little brief introduction to our network. So sorry. Before the MHTTC is a nationwide network supported by SAMHSA. Our network includes 10 regional centers and a network coordinating office, and you can see they're highlighted in the bright pink circle at the top. The Northwest MHTTC covers HHS Region 10, which includes Alaska, Idaho, Oregon, and Washington. Our goals at the Northwest MHTTC are to support mental health-related evidence-based practices, heighten awareness, knowledge, and skills of the behavioral health workforce, foster alliances and address diversity of training needs, and to share free publicly available training and technical assistance. Our areas of focus include evidence-based practices for serious mental health issues and psychosis, such as CBTP and ACT. We also provide a wide variety of other trainings as well. Please do check out our website. There you'll find a listing of upcoming and previously recorded webinars and learning communities, online self-paced courses with healthy knowledge. You can sign up to receive our weekly newsletter. You can also review our resource library and listen to our podcast called Putting It Together. So for today's webinar, we will send out a link to the recording, the slides, and as well as your certificate of attendance within a couple weeks after this event. So be looking for that. And important information about today's webinar. On your screen, you will see a chat box as well as a Q&A box. For chat, please use the chat box if you need help from any of our staff, or you'd like to share respectful comments, greetings, and observations to everybody in attendance, which everyone is doing, which is fantastic. Thank you. Please use the Q&A box to type in any questions for our presenters. You can do that at any point throughout the presentation. We will be monitoring the Q&A box to facilitate answering questions at the end of the presentation. Oops, I lost my mouse. Okay. So after the webinar, we ask that you do fill out a survey. Please know your feedback is very important to us in the work that we do, and we do appreciate everybody trying to fill those out. Our team will share the link in the chat. You will also get an email reminder via Zoom tomorrow. We are required by SAMHSA to conduct the survey, yet they do not have an official position on our content. And I keep losing my mouse. I'm so sorry. We do have upcoming webinars too on our website. Please check them out. Tomorrow, actually, Tenant Law Group or Tenant Law Center is coming back. They are going to have a webinar on making room for mental health, reasonable accommodations, and modifications in housing. And then we do have a sexual health series happening, and our next one will be Wednesday the 29th, discussing and documenting sexual orientation and gender identity. With that, I would like to welcome to today's presenters. Kaitlin Touza is a pain psychologist and acting assistant professor at the University of Washington Center for Pain Relief. She provides evidence-based individual and group intervention, including CBT, ACT, EAET, and PRT. She also provides consultation to a broad population in the Pacific Northwest region and Alaska through UW's TelePain program. We also have Bethany Pester, a pain psychologist and acting assistant professor at the University of Washington's Pain Center. Her patient-centered approach incorporates evidence-based psychological treatments for chronic pain, such as CBT, ACT, EAET, and PRT. And we have Eric Wanzel, is a master's level therapist at the University of Washington Center for Pain Relief. Eric is a special interest in the intersections between chronic pain and PTSD and provides evidence-based practice interventions to populations including CBT, ACT, PRT, CPT, PE, and WET. And last, we have Elizabeth Paulson. She is trained in anesthesia and pain medicine and treats patients at the University of Washington Center for Pain Relief and Harborview Medical Center. She has a special interest in post-traumatic pain, PTSD, and pain in older adults. And I will hand it over to you all. Thank you so much for being here today.
So it looks like the title screen should be up there. As Amy mentioned, we're going to be talking about a biological model for chronic pain and strategies to support both the sensory and emotional experience of living with chronic pain or with pain. Know that this will not be completely exhaustive. We do aim to cover as much as we can, but this topic can be quite extensive. We will save some time for questioning near the end. As far as disclosures are concerned, we do not have any financially relevant disclosures to disclose on this day, but we do like to point out that we do hold some very sincere beliefs. First of all, that all pain is real and that all pain is biopsychosocial in nature. And that we do also believe that the more people understand chronic pain, the better treatment outcomes they have. And part of that really comes down to the idea that we can hurt, but it doesn't necessarily mean that we're doing ongoing harm to our system. So the idea that we can be sore but safe, because pain ultimately acts as a means of protection. And that being said, pain is complex and everything matters when it comes to chronic pain. But most of all, we know that recovery is possible. So a little bit about where the four of us come from. We all work at the University of Washington's Medical Center's Center for Pain Relief. We are a national center for clinical excellence that serves a large region because we're the only tertiary chronic pain clinic for Washington, Wyoming, Alaska, Montana, and Idaho. So that's slightly different than the regions that we're focused on today. We are primarily a consultative multidisciplinary approach that works with people who are referred to us usually from primary care or other specialty clinic when they're reaching barriers in improvement. We have a multimodal and multidisciplinary team that kind of fluctuates a little bit based on staffing patterns, but typically includes anesthesiology, neurology, holistic medicine, psychiatry, psychology, and social work. In addition to consultations regarding medications and other approaches for chronic pain, including behavioral health, we also do a wide variety of interventional approaches that are complex in nature, that include a lot of regional nerve blocks, non-opioid medications, sometimes individual or group training and relaxation and coping with that too. And we'll be talking a little bit about some of those things that we do here today as well. And so our main objections for today are to define pain and to understand the different types of pain. Because even though they might feel the same, they're very different in how we approach treating them and also what's going on kind of underneath the surface of that pain. And part of that is really to understand the biopsychosocial model as it applies to both the etiology and treatment of chronic pain. And included in that is building skills and delivering pain neuroscience education, which in and of itself is an effective intervention for pain. So we'll be spending about 15 or so minutes on that today. And in addition to that, we're going to be exploring some diverse strategies for supporting the needs of people experiencing chronic pain, because some of the things that we ask of people experiencing chronic pain seem like the opposite of what they want to be doing in those experiences. And the educational pieces really come into play with that. And we also want to provide you some additional resources for education and management, because we know that this can be a complex population, and we want to be here for as much ongoing support as we can provide. So let's start today's conversation with a tale of two nails. These are both real case studies. That one was in 1995, the second in 2005, both involving two separate construction workers. The first of which was working on a construction site and jumped down from an elevated kind of stance and landed on about a 6-inch nail. The 6-inch nail went cleanly through his boot, and he was understandably in agony. And so they treated him with a lot of medications. They went through pretty much everything that they could in that moment to try to provide some assistance. But ultimately, what relieved his pain was when they did some imaging and removed the boot and saw that the nail had gone cleanly between his toes, not causing tissue damage. So pain can happen without injury. The second story involves another construction worker, dangerous job, working with one of those nail guns. And the nail gun backfired and hit him in the chin. And so he had no visible wound, just a little bruise and a toothache. Person assumed that it was a faulty discharge and felt relieved that he didn't have greater injury as a result of this. And so he went about his week, eating, sleeping, brushing his teeth. No significant alarm or alert, but some dental pain. And so about a week later, he went in to go see the dentist. And like dentists do, the first thing that they do is they do some imagery, they do some x-rays. And what they had found is that the nail had gone through the roof of his mouth, nearly touching his cerebral cortex and causing an emergent need for medical attention. So he had an injury without acute pain. So what does that mean to us? What is pain? And I'll go ahead and pass that over to Kaitlin to talk a little bit about that for us. You're muted, Kaitlin.
Thank you. Okay. So we first want to just point out that whatever comes next, however this is thought about, all pain is real. It's a subjective, real experience that people are having, but it's also perception. It's perception of different signals that suggest something's going on and we need to pay attention to it. So pain has a purpose. It is a survival-focused navigational sense. It's a learning mechanism, and it changes behavior to protect the individual. So it has a purpose, it has a reason for showing up in certain scenarios, but pain perception is produced by the brain, and we want to avoid sending the message that pain is all in your head. We want to think about all perception being all in our head at the brain level, whether it is pain or vision or feeling hungry or feeling tired. All of these things are experiences that are produced by brain processes. So pain itself is a sensory experience or a perception produced by the brain in response to signals that indicate tissue damage has occurred or the potential for tissue damage to occur if behavior isn't changed. So we want to think about pain like the fire alarm and not the fire. So pain is not the injury. Pain is an alarm bell that lets us know that there may be an injury. So you want to think about pain as a useful warning, learning, and navigational sense, but distinguishing it from the idea that pain equals harm, as Eric mentioned earlier. Some examples of this that we can all relate to are things like when we go out in the cold and we feel pain a long time before frostbite sets in. So it can be a warning system that gets us to seek safety when we're in an environment that could be dangerous. We know what it's like to hold a hot cup of coffee and have it be too hot and feel like we have to put it down, and we put it down before we get a blister. So again, that pain showing up before something is being damaged to get us to change our behavior and ultimately be safe. And you think about times where you're moving or you're exercising, and at a certain point your body starts to hurt, and that's a signal to take a break. So it's a helpful navigational sense that we use in everyday life and is not necessarily only associated with injury. Next slide, please. But we also want to think about the differences between acute and chronic pain, recognizing that all pain is real. All pain is both a sensory and emotional experience. So it's a processing of both of these things. But with acute pain, we think of acute pain as helpful, as useful. Acute pain means survival. Listening to those pain-related signals will help us to, avoid aggravating tissues as they heal, will help us to rest and stay safe during illness processes. And so acute pain, useful, survival focused. It usually has a pretty clear cause. We know what causes it, and the treatment is focused on cure, and it's usually a pretty targeted treatment, maybe more biomedical. With chronic pain, we want to think about it like it's real, but it's not helpful. So this pain is a real experience, but it's not necessarily safety related. If you think of the purpose of pain, meaning it guides us away from dangerous experiences or things that could cause damage, then if our body is doing what a body's supposed to do, it shouldn't really hurt, right? So chronic pain doesn't really make sense from that sort of purposeful pain perspective. We also know that with chronic pain, it's usually a complex cause, so it's not as straightforward as far as treatment goes. Treatment is often multifactorial, and with chronic pain, the pain is the disease, whereas with acute pain, it's a symptom of the illness often. And then again, with chronic pain, we are looking at a multidisciplinary or transdisciplinary approach to treatment. Usually we're focused more on management and improving function, as opposed to acute pain, where we're looking for a cure for the disease that might be, or the issue that might be causing that pain. Next slide, please. There are different types of pain, and this can be helpful, especially if you're getting into pain management, to understand, because it can help to demystify a little bit of why there are so many different types of treatment and things that people might go through. One is nociceptive pain. So this is pain that is elicited from the activity of nociceptors, or the activation of pain-related signaling neurons in the body, sending that information up into the central nervous system. And these, for example, acute injury is that type of pain. And also chronic pain diseases, so diseases associated with chronic pain like arthritis can also have a nociceptive component to that pain. So it can, part of it will be an ongoing activation of the nociceptor for some chronic pain conditions. Next slide, please. Neuropathic pain is derived from some change in nervous system activity or nerve activity, often related to damage of the nerve due to lesion or disease. And so a change in the activity of that nerve. And this is common in diabetic neuropathy, carpal tunnel, and complex regional pain syndrome. So again, some chronic pain conditions that are associated with this change in nerve activity. Next slide, please. And then the last one, nociplastic or primary pain. This is thought to be caused by a change in the processing of pain-related information at the central nervous system level. So changes in the way that the brain and the spinal cord are processing those pain-related signals or nociceptor signals. Fibromyalgia, TMJ disorders, or nonspecific low back pain are some examples of this, but certainly a lot more than that. Next slide. And then this is probably the most important point here. Most people are experiencing some combination of these different pain-related factors. So some combination of a central mechanism combined with some of these other nerve-related or nociceptor-related mechanisms driving pain awareness.
And so we've kind of alluded to the fact that pain is complex. And so in order to really look at the complexity of pain, we need to look at it through the biopsychosocial lens, because of a lot of the ways that the pain becomes chronic. And I'll talk a little bit here about kind of the biopsychosocial kind of model for pain and the chronification process. But before we do that, I just wanted to talk a little bit about history, because personally, I tend to be a little bit of a history buff, and history and context can be helpful. Really, interdisciplinary or multidisciplinary treatment of chronic pain was originated by John J. Bonica, who actually started our clinic here back in 1960. He's an interesting character. His father died when he was 15, started working to provide for his family, and eventually kind of became a doctor who was also a national wrestling champion in 1941. And he also is the founding father of the discipline of pain management. Because in 1942, after finishing medical school, his wife at the time had become pregnant. He was in the delivery suite with his wife. His wife had taken the medical team saw that she was having some difficulty with labor. And so they had attempted to administer some ether to help her through the labor process. That didn't go that smoothly. And Dr. Bonica saw his wife and future daughter potentially dying and turning blue there in the labor suite. And so he jumped in, saving both his wife and his daughter, in order to then turn and dedicate his life to anesthesiology and eventually kind of really revolutionized the process. And so this is 1942. By the time he had finished anesthesiology kind of rotations and kind of was going out into the world, this was right after D-Day started. And so in 1944, he joined Madigan Air Force Base, or Army Base at the time, it's joint now, where he was in charge of managing the pain in a 7,700 bed facility. And this experience really taught him that, you know, this is not what I had learned in school. I'm seeing people with pain in limbs that they no longer have after amputation. I'm seeing pain without specific injury. And so he began kind of going around to his colleagues in the hospital, both within the Army base and then later down at Tacoma General before transitioning to UW, where he began consulting with any psychiatrist, neurologist, so any number of professionals he could get together during a lunchtime committee. And after kind of seeing that the data and the literature didn't really fit what he had been taught, he started a process of reviewing the world's literature on pain. So over 14,000 pages of literature, and pain was only mentioned on 17 and a half of those. And so he really began to focus that pain is one of the most important aspects of the patient's experience, and the medical community is not talking about it. So he began to develop new practice, kind of bringing together the professionals throughout the world, and published what has been referred to as the Bible of Pain in 1953, the management of pain. And before then founding the Department of Anesthesiology here at UW and the first multidisciplinary pain clinic. By 1974, he went on to found the International Association for the Study of Pain. And by that time, there were hundreds of multidisciplinary clinics throughout the world. So this was an evolution in the treatment of pain that happened rather quickly and profoundly too, to change the patient experience. I included this link on the bottom. It's a really good TED Talk. It's about 15 minutes. It goes into a little bit more detail and talks about this story a little bit more than I do. But what we really see is that by the end of this process, or by the 1970s, we had really seen the multidisciplinary approach to pain come into play. And when we look at the biopsychosocial approach, when we take a look at things throughout the biopsychosocial approach, we realize that everything matters. And I like to go back, again, history, kind of looking at quotes from ancient Greece, where men are disturbed not by things, but by the view which they take of them. And what we begin to see through some of the work later through Turk and Monarch is looking at the difference between disease and illness. Someone might have osteoarthritis, but that's not the full illness. That doesn't talk about all aspects that pain impacts. It impacts their psychological approach to the world, to their mood, affect, stress, coping, and kind of how they interact with other people. So we begin to see that we need to look at chronic pain through this lens as well. And so when we talk about the biological, kind of biomedical focus of chronic pain, this is the experience that most of our patients come to us with. Like, there's a problem, we need to fix it. Is there a medication, a procedure? Can you cut this out of me? That's really the approach that a lot of people come in. I want to be a passive patient, fix me. And that's a lot of the biomedical model. And if we look at the average primary care physician's training in the US, on average, they receive about 4 hours of training in pain. And within Washington State, they are required to have 1 credit of continuing education on opioid prescribing to kind of take on some of that management. And so if we're just looking at this through the biomedical model, we're not looking at all the different factors that are impacting pain, because we know that the psychological experience matters as well. This is how people are coping with the pain. This is people's mood. This is people's affect. This is people's fear of re-injury. And what we know through a lot of the research is that there are a number of trait and state psychological characteristics that impact pain, whether that's personality, learning history, environmental supports, beliefs and expectations, things like anxiety, depression, anger, and their own personal histories that may include trauma and PTSD that really impact the nervous system. And so we need to look at treating those aspects, because without treating those aspects, we don't see the improvements in the underlying pain. So the condition that might be causing their pain could be the osteoarthritis, but comorbid trauma history could cause some of that nociplastic pain that Kaitlin talked about, and kind of turning up the volume on the nervous system to really amplify that pain generation. So this is where pain becomes complex in a lot of different factors. We also know that the social or sociocultural aspect of pain is huge, because if we think about these are our social determinants of health. These are the situational and contextual stressors that amplify stress and therefore amplify pain and the response of our nervous system. Another way to think about this is that if we reflect on kind of Maslow's hierarchy of needs, if your physiological needs of safety and security aren't met, if you don't have a sense of belonging or love, that internal alarm process is already going to be amplified. And so this might take referrals to social services to help meet basic needs, to talk about work retraining, to talk about how cultural factors and even language can impact how we experience pain. And so what we really want to encourage, and at least have people think about a little bit, is how we shift more away from that medical model of chronic pain and move into seeing it as more of a biopsychosocial experience that can be treated. Because if we look at the biomedical perspective, there's a single cause, so there's a single treatment. Where if we look at the complexity of disease and illness, we need to look at multiple different aspects at the same time. We need to be more focused on health and positive change opposed to disease and deficit. We tend to take more of an interdisciplinary approach instead of this will be treated with a surgery, an injection, or a manipulation. Because one of my favorite pieces of research to kind of look back on is that there was a study that looked at your likelihood of getting a knee replacement for knee pain. And it wasn't about the severity of your symptoms. It was about how close in geography you were to someone who did a knee replacement. We tend to look at the tools that we have. And so if we broaden this to more of a biopsychosocial or interdisciplinary approach, we have more tools. And we know that surgery can make pain worse, and that we can have poorer outcomes with surgery. We also want to look at decreasing the sense of harm within ourselves, others, and the world. Because if we don't feel safe, we're more likely to feel pain. And we begin to kind of look at a lot of the psychological and psychosocial aspects of disease that all impact these different domains. And so in looking at that, how does pain become chronic? And that's a complex factor that we're in a lot of ways still theorizing about. It's not necessarily set science. But if we think about it, we experience a stimulus, whether that's physical or emotional, that leads to discomfort or pain. And then as a result of our attention to that, we might develop fear, stress perception, anxiety, a fear of re-injury, and we're more likely to pay attention to that as a result of that fear and that stress response. So these are the social, biological, and historical learning that are taking place and impacting our overall pain perception because we're giving attention and focus to it. When I'm talking to individuals who are experiencing, like, let's say, chronic left or upper extremity pain, they're really focused and they're giving attention to the sensations that they're having in that left arm, but they might not be paying attention to the sensations that they're having on their right pinky toe. And so a lot of our attention then changes the way that we remember, learn, and then kind of neuroplastic aspects of pain, because we change our behavior, we change our thoughts, and we have a change in our emotions, which impacts our working memory. And then as a result of that, we shift that into more of our long-term memory, where we might be, avoiding activity because of that fear of reentry. We might have decrease in activity because when we move, it causes pain. So therefore, it must not be healthy or good for us in that moment, which leads to physical deconditioning and sometimes muscle atrophy that then can increase maladaptive movements and kind of decrease fatigue or increase fatigue. So we really see kind of the complex nature of those processes kind of coming into play. And so within a lot of this kind of chronification, we see people take on more of a passive coping approach, whether that's through guarding. So they're protecting their body to try to brace or limp to protect a part of their body from additional pain or reentry. Guarding behaviors as we're continuing to heal can cause other aspects of our body to hurt, or they can perpetuate the fear of reentry in those situations. And in addition to guarding, we also tend to see patterns of resting and underactivity, which can lead, as I said, to muscle atrophy. And so we need to begin to look at helping people reverse some of these processes that they've learned throughout the process of kind of the chronification of pain. And so another aspect of this that we tend to look at is kind of the fear and avoidance model with chronic or persistent pain. Is that being in pain is stress on our system. No one likes to be in pain, or very few people like to be in pain. I'll rephrase that because I don't like to make absolutes. And so as a result of that, an individual might avoid activity due to fear of inducing pain, and then they limit their overall daily function. And so this becomes a misinterpretation as the pain as being the catastrophe. And so when we're viewing it as that catastrophe, individuals continue to avoid the pain-inducing activity, like walking, like doing things around the house, that then increases their sensitivity to pain and discourages exercise and weakens the body, and then further compounds the problem. And so, Kaitlin, would you like to talk about what's going on at a neuroscientific level with pain?
I really would. It's my favorite topic. So just a reminder, pain is a perception, just like any other perception, something that we're aware of, that occurs at the brain level in response to some kind of indicator that tissue damage has occurred or that it will occur if behavior doesn't change. So, that tissue damage indicator can come from nociception, or it can come from other sensory experiences, like that example of the nail going through that person's toes. He had a sensory input that suggested injury. It was visual, right? So it can be that, or it can be the central mechanism that has to do with changes at the brain level that essentially change our pain processing system and result in increased sensitivity to pain. So pain is the sensory indicator that, is about avoidance of danger. It is meant to draw our attention and change our behavior so that we stay safe. And your nervous system's job is to keep you alive. So your nervous system, especially your central nervous system, is a danger and error detecting machine, which means it has to have a negative bias. So it's better to assume that it's a tiger and find out it's a kitty cat than go the other way around. So we just have a tendency to be danger focused and somewhat reactive, and even reactive to things that are uncertain. So not knowing why something hurts is a stressful thing to have, to not know why it's happening. And one last thing on this slide is that pain is a powerful teacher. It guides our behavior, and we remember painful experiences in more detail and with more emotional intensity than other types of experiences. So whether it is physically or emotionally painful, we remember things differently, and it'll impact our behavior when we're in a similar scenario in the future. So let's talk a little bit more about what is actually happening at the brain level so that we can maybe demystify a little bit of why these biopsychosocial factors matter for pain perception and living with pain. And because I think that going into detail on these concepts can be helpful for both patients and healthcare practitioners to make sense of their experience, whether it is in treating pain or experiencing pain ourselves. So, kind of making sense of fluctuations in pain intensity and unpleasantness that don't necessarily match up with activity, for example. understanding how chronic pain can change over time. And hopefully, as you go through this, education with yourself and with a patient, understanding what self-help and self-management strategies are useful to that person, and that person actually understanding why they would be useful. So you can see on the left some of the brain regions that have been associated with pain processing and with chronic pain processing. But I think it's a little bit more helpful to talk about what those areas do, as that list of, brain regions will likely be, fine-tuned and added to as research continues. But these brain networks that are associated with pain processing and pain awareness are also the same regions and networks that are involved in things like emotion processing, memory formation, threat appraisal and associated behavior change, attention, both on purpose and involuntary, self-regulation and self-awareness or consciousness, planned behavior, and motivation and reward. And, as you're listening to that, you should think also that those are complex brain networks that are involved in a lot of other things as well. These are, networks that are involved in the integration of sensory experience with emotion and memory. So things like worrying about pain or being distressed by pain. And also the endogenous opioid system, which we often think of as, responsible for our downregulation of pain experience. But it's also responsible for things like social function and bonding, attention and focus, and again, motivation, reward, and enjoyment of things. So it's the same system that's involved in pain regulation is involved in all of those other processes as well. So what you want to take away from that is that a lot of things can influence pain perception. And we can also influence our pain perception by considering some of the factors that might influence these other things that these brain networks are involved in. We're just talking about the move from acute pain to chronic pain. So you want to think about how how the brain changes when we are moving from acute to chronic pain. Some of the things we see are changes in gray matter volume in these areas some of these areas that are associated with pain processing, meaning that there are, fewer or there's less cell volume in that area, as well as changes in functional connectivity. So how these different areas of the brain are talking to each other also changes in association with the development of chronic pain. But we also see those things change again when people start to get better, when people have less distress associated with pain, when function improves, and when actual pain severity or the perception of pain severity improves, that some of these changes associated with chronic pain also change again. So we can, sort of unlearn or relearn some of this pain processing as we see changes in the impact of pain on life and well-being. Next slide, please. But theory will only take us so far, especially if, that explanation of different factors that influence pain don't match up with the patient's personal experience, their lived experience, perhaps their medical advice they've received, and certainly if it doesn't match up with their experience of injury or tissue damage correlating with increases in pain. So it's not that simple. And so it can be helpful to give examples that challenge that perceived connection between pain and tissue damage, and kind of giving the impression that pain might actually be a relatively poor indicator of ongoing issue or of the severity of an issue. Perhaps there might be other factors that may be better ways to judge that. And so showing examples like this image can help. This is an image of incidental findings of these different issues or changes in the body associated with aging that were found when people were getting imaging done for other reasons. So these issues that are in this image were not associated with pain. But these same issues or changes associated with aging are associated with substantial pain burden and functional impact for many people. So kind of having something like this to help get us questioning, well, what is going on for me? Why am I experiencing this if other people don't? What might be contributing to my experience? Can get us to start thinking perhaps a little bit more about roles of behavior, of thinking and mood, and any other factors that we might be able to bring in to think about what might be contributing to this pain experience, as well as those examples of hot and cold or movement-related fatigue and things like that. That tale of two nails. These are all good tools to maybe help us to start thinking about pain in a little bit more nuanced way or as more complex. Next one, please. So let's kind of zoom out and maybe have some visuals that help us to conceptualize pain processing a little bit more fully. So nociception, again, nociceptors are these neurons that pick up information about tissue damage, whether it has already occurred or if it's likely to occur if the stimulus is not removed. So you might think of nociceptors as activating when something has already happened or when we are approaching the protect by pain threshold, meaning pain showing up to get us to change our behavior, to go seek warmth or to take a rest, that type of protect by pain threshold. These nociceptors, their behavior can change based on things like inflammation or peripheral sensitization, essentially meaning they're sending information to the brain more frequently. Inflammation is also likely playing a major role in central sensitization processes. So some of those processes that might lead to that primary pain or that centrally mediated pain sensitivity. And so information is sent potentially, if that's where the information is coming from the body up into the brain through the brain stem, spinal cord up into the thalamus. Once it's up there at the brain level and being sent everywhere by the thalamus, which is what the thalamus does, then we have some cognitive processing going on. So some threat appraisal process of what is it? What do I need to do about it? How serious is it? And so that we got to notice it. So we have to notice what's going on. We are aware of something. Then we interpret it. We have a cognitive appraisal process. Our emotions are reacting to what's happening as well and guiding some of that cognitive appraisal. And our behavioral response is, largely guided by whether or not it's something that we need to do something about or not. Is it threatening or not? And so these processes, what we're noticing and what we're thinking about what's going on, how we feel about what is happening is ultimately going to influence our pain perception, both through this descending inhibition or descending modulation that goes down back into our spinal cord and impacts whether or not sensory information is being, processed by the brain. We have sort of a feedback loop of neurons that can influence whether or not information is being transmitted. As well as at the brain level, are we noticing what's going on? Have we noticed something happened, like that example in The Tale of Two Nails where there was an awareness of an injury? And if we are aware of something happened, what do we think about it and how do we feel about it? So all of that stuff will matter. And then also recognizing that autonomic reactivity is also going to influence and be influenced by these cognitive processing factors, and that is also going to influence pain perception, because what our body is doing, our brain is, taking into the context of danger analysis. If our body is activating as if we're in danger, then we are going to perceive things as potentially more dangerous. So we can also use that as a tool by calming our body down and creating an incongruent autonomic experience that, kind of teaches our nervous system that what's going on is not so bad, that we must be safe. So using some of those physically self-soothing calming techniques in the presence of a difficult experience, whether it's pain or something else, can reduce some of that autonomic activity and change what's happening at the processing level. So all of this, combined with what we were just thinking about with brain regions and functional connectivity with outward stuff in the biopsychosocial sphere of what's going on around us, what has happened in our past, what are we thinking about in our future, all of this combined, along with these inflammatory properties and everything else, the excitability of the nociceptors are contributing to whether or not somebody notices pain and whether or not they're bothered by it. So kind of thinking about all of these pieces coming together and needing to think about this with some nuance. Next slide, please. This is what I mean by the protect by pain threshold. So just to give a little bit of information, because this is relevant to many of the things that you might do with somebody who's dealing with chronic pain. Before chronic pain shows up, or maybe in a period of time where somebody's pain burden is lessened for various reasons, we might have a lot of room for activities, for sensory exposure, for movement, for even non-movement, for sitting still. We might have a lot of sort of time or ability to expose to that thing before our pain shows up to say, stop doing that, take a break, go get warm, move around a little bit. So whatever that signal says to change our behavior so we feel better. If we are operating within a system that's sensitized, whether it is a peripheral sensitization related to changes with the nociceptor behavior, a central sensitization with changes at the brain level leading to perhaps an increased processing of this pain stuff, or reduced down modulation, meaning we're noticing it more and with more intensity, or it's some combination of all of these things together. What ends up happening is that warning signal, that protect by pain signal, shows up earlier on, and is often, there's many reasons for that, from previous experiences showing, being painful, teaching us to avoid that activity, and so then our nervous system starts warning us against it. Emotional experiences that might influence what our nervous system is dedicating attention to, or even something like having difficulty sleeping, influencing this, our body activity, from the nociceptor to the central nervous system to the inflammatory level, all of those things combined, and autonomic. So it can be a lot of different factors that will go into whether or not our pain warning is coming on earlier than we need it to, or whether or not it's a helpful signal for us in that moment. Next slide, please. So it can be helpful maybe to go through a little bit of this stuff. This, it reflects the biopsychosocial model and our understanding of different factors that influence pain. This is by no means an exhaustive list. We could have, a whole day presentation going through each of these, and even things that are not on this list, and going through some of the, rationale and science behind our understanding of these things. So it gets to be a big picture. So we'll go through some of the ones that are, maybe brought up the most, and that we can, think of as perhaps the most helpful. So thinking about changes in pain signaling, awareness, and the functional impact is associated with all of these things to some extent. For each person, it might be varied, and ultimately depend on their personal context, how much of each of these factors might be contributing to their experience. We used to think about these factors as modifiable or non-modifiable. But really, what we think about now is that whether or not something in the past is modifiable, or a factor in somebody's life is modifiable, the way they feel about it and the way that they think about it is modifiable and constantly changing. So even within the non-modifiable factors, there are still changes that occur, as somebody is thinking and moving through life and experiencing things differently. So anxiety, depression, and stress. Chronic pain is linked with depression. It's a bidirectional relationship. They influence and predict each other. 20 to 50% of people with chronic pain also have depression. So a big cohort of our people with chronic pain. And depression is an independent risk factor for chronic pain. It's also known to modulate pain perception independent of tissue injury. So the level of depression symptoms that people are experiencing will modulate pain perception, whether or not there's identified tissue injury. Speaking a little bit more about stress, early life stress is associated with long-lasting changes in pain perception. It's also associated with changes in systemic inflammation in adulthood. So there's, some biological and psychological associations with pain and stress. Anxiety is, occurs in about 60% of people with chronic pain. So again, a high correlation there. And all of these things, anxiety, depression, or stress, are associated with, elevated inflammatory markers and reduced descending inhibition, meaning your central nervous system isn't doing as good of a job of filtering out pain signals. So everything is, we're aware of it all, and it's all intense. We also know that some of these mood factors are associated with increased peripheral and central nociceptor excitability. That means these nociceptors, these tissue damage indicating neurons, are more active, and it's easier for them to send those signals. Next slide, please. And I could, again, we could have a whole presentation just on that last topic I just went through. So just know that it is much bigger than what I just said. Fear of pain may be of particular importance in to address when you're working with patients with pain. Anxiety and fear about pain is associated, again, independently with a risk factor for developing chronic pain. And fear avoidance behavior in particular may be important there. Catastrophizing seems to play a role in central sensitization. So the way we think about pain and how fearful we are in our thoughts about pain, or how, again, catastrophizing, whether or not we're doing that. We also think it is a contributor to hypervigilance to symptoms. So paying attention to that body part with more intensity, perhaps, as Eric brought up earlier. And then, associated with sensitization. So thinking about it also being a factor that leads to increased sensitivity to pain through various mechanisms. Next slide, please. Sleep is another one that could have a whole, day dedicated to it. It also has a bidirectional relationship with pain, meaning sleep disturbance influences pain, and pain influences sleep disturbance. Insomnia, again, is an independent risk factor for chronic pain. And that, you know, just thinking about how sleep disturbance is going to influence, you know, neurological, biological, hormonal systems that regulate things like inflammation, mood, reward and aversion behavior, all sorts of things that also are influenced and influenced by that influence and are influenced by pain. Also considering that if you improve sleep and you do nothing to treat pain, pain will also improve. So sleep is a target in and of itself when we're dealing with chronic pain. Next one, please. This is another big topic. We know that when people have had a significant amount of trauma exposure, particularly certain types of trauma in early childhood, but certainly other types of trauma as well, we see in those people changes in dopaminergic, serotonergic, and opioidergic systems in the brain. So there's a change in the way that the brain behaves in response to having early life trauma or repeated trauma. And we see alterations in immune system function and the HPA axis function, which has a lot to do with stress hormones and things like that. So, you know, leading to other challenges in those bodies of people who have had a lot of trauma. And again, PTSD itself is associated with increased risk for certain types of chronic pain. And again, that's a big topic that could, you know, but we think that trauma is influencing the body, the brain, the hormones, the, you know, the autonomic nervous system, all of these things ultimately being part of our pain processing system as well, and our danger processing system, truly. Next slide, please. Health behaviors, there's all kinds of things that we ask our patients to consider when we're trying to improve experience of living with chronic pain. Some of the ones are obvious, like smoking and alcohol use. Both of these impact healing, increase inflammation through different pathways, and both reduce descending inhibition of pain. So both alcohol and tobacco are associated with increased pain sensitivity because of the way that brain is not sort of reducing our pain awareness the way that we usually have it, or the way that it usually does. You also think about physical inactivity versus exercise. Physical inactivity is an independent risk factor for chronic pain, and exercise is protective against multiple types of chronic pain. In particular, the ones that I've seen are things like neck pain, low back pain, and shoulder pain, for exercise being protective. We also want to consider things like food habits and nutrition, knowing that nutrition and what we eat is a major source of inflammation, systemic inflammation. Thinking about whether or not we're getting the nutrients that we need. Sleep behaviors, we just talked about sleep, but we got to consider whether or not we are doing the things around sleep that protect our sleep and help us to sleep with better quality. And then relaxation practices, self-care, and leisure are also things we want to consider when it comes to health behaviors and management of a chronic stressor, which we consider pain being. Next slide, please. Immune system function is a huge topic, but altered immune system function is associated with both peripheral and central sensitization, as I said earlier. It's also, there's pain specifically associated with types of neurogenic inflammation, or we think at least that might be leading to the pain condition that we are seeing associated with neurogenic inflammation. And, inflammation itself, one of the purposes of inflammation is to make something hurt and to make the area that hurts expand so that we keep ourselves safe while we're healing. We remember not to use that part of our body. So helpful in acute injury, not so helpful in chronic pain, where it's going to make everything that hurts hurt more. It's actually altering the activity of those nociceptors to send more information to the brain more quickly and more easily. Next slide, please. GI function, again, major source of inflammation. Things like leaky gut in response to eating inflammatory foods can be a major cause of pain, as well as things like brain fog and fatigue that are often associated with pain. Think about the gut-brain connection and how emotions are also part of that and regulating, as well as regulated by that. Inflammatory bowel conditions and GI upset are fairly common with all kinds of types of chronic pain. So again, a symptom that kind of hangs along comorbid with other types of chronic pain. And we also think about the impact of medication side effects on GI function. So when treating pain, we might also end up with changes in the GI system that might also lead to discomfort or pain. Next slide, please. Surgery is a risk factor for chronic pain, especially moderate to severe pain prior to surgery. Anxiety about surgery is associated with increased risk for chronic pain. Acute post-surgical pain, and I'll talk, again, there's another mention on that later. And then infection after surgery. These are all risk factors for chronic pain, and there's a lot more involved in that as well, too. We could keep going. Next one, genetics. They have identified at least 150 genes associated with chronic pain, and we do think there may be some genetic factors that may predispose us for maybe more vulnerability to chronic pain. There's also these genes that are associated with immune function, inflammatory factors, and stress, which are likely, part of this whole picture. Next one, medical comorbidities. Again, big list here. You might think about some of these. Obesity, for example, is an independent risk factor for chronic pain. Comorbid physical and mental chronic disease, increased risk for chronic pain also. So just having a lot of disease burden. Increased chronic pain is associated with depression and cardiovascular disease, even when controlling for other factors. So those two things together are particularly risky for developing chronic pain. About a third of patients with coronary and pulmonary diseases report chronic pain. You also think about complications from intervention and how that might result in chronic pain, as well as how treating chronic pain might complicate intervention for other disorders as medication interactions or other things come up. And then there are, many medical conditions that are just associated with chronic pain as a symptom. Another one that I would just mention there is viral infection, as we're finding out more and more about things like post-viral illness and symptoms, that may be, again, a piece there to give it particular attention to. Next one, poor acute pain control. So think, pain control after surgery, after injury, something like that. That seems to be associated with increased risk for central sensitization. So as pain is not controlled well after an injury or after surgery, it may increase that risk of developing that change in the brain. Next one, occupational risk factors. There's a lot to explore here. Occupation, work environment, and various, factors involved in the work environment can be a risk factor for chronic pain. Some of those are lack of ability to modify work, fear of re-injury, poor job satisfaction, higher perceived job difficulty, having to do repetitive movements without the ability to modify, job insecurity, working long hours, poor relationships with colleagues, poor work-life balance. I'm sure we've all had experiences that we could tick off some of those things on that list and think about how it impacts us. Next one, environment. Big one again, could have a whole, hour on this, but some of the ones that come up often are things like sun exposure. So think about vitamin D level and intake, weather and temperature, especially for certain types of chronic pain like arthritis seem to be particularly bothersome. Air pollution as well for arthritis is one that comes up. Disruption in sleep schedule and maintenance. So what's going on around you? How well are you sleeping? Again, social support, interaction, and empathy. All of those seem to result in lower levels of chronic pain severity. And then the last one we always forget is, are you having any fun? Leisure and activity. That was back in the environmental section. Physical inactivity, we've talked about a little bit already. In the interest of time, I won't go over it too much. I'm in physical inactivity now. But just thinking about physical inactivity is a risk for health and likely chronic pain. It is, it's associated with, being more physically active in recreation. So doing fun things, leisure activities that are active may be protective against development of chronic pain, especially certain types of back pain. And that also we think about the physical activity increases function in that endogenous pain inhibition system, meaning that downward modulation of pain. The more that we're moving and enjoying our time while we're moving helps our brain to down modulate pain awareness. So it actually helps that system. So sort of the opposite of central sensitization, maybe. Next one. Altered body perception. So when people have experienced chronic pain for long periods of time, we see changes in how they perceive their body. So altered proprioception, so awareness of body and space, awareness of body movement, things like that. There can be changes in left-right discrimination depending on the site of pain and the type of pain somebody's experiencing. We see reorganization in the sensory cortex. So the sensory cortex essentially can become less distinct when it comes to judging where on the body a sensation is coming from. This is also associated with things like guarding behaviors, where we become less aware of perhaps what our body is doing. Aversive feelings toward body parts, so disliking parts of our body or even feeling detached from our body. All of these are associated with experiencing chronic pain. we'll go on. We'll move on to the next one. Okay, so let's bring that all into something that would be useful to a patient, right? That's helpful for us to understand so that we can conceptualize what our patients might need, but not always as helpful to go into that much detail when you're actually talking to somebody. But it can be more helpful to think about how we can bring that pain neuroscience into something a person can take action on. So breaking down behavioral, cognitive, environmental, and social factors that may influence pain perception or processing, and maybe help that patient or that person recognize their role and agency in their management of their chronic pain, and help to maybe see why perceived pain severity might fluctuate on, resulting from other things than just activity or a medical intervention, that there may be other factors that are influencing that awareness of pain. Kind of looking at also breaking down myths like, exercising past the point of pain, things like that. We want to recognize that both overdoing it and underdoing it is, associated with increased pain sensitivity. So, recognizing that there are, ways to approach movement that might be different from the way that somebody is doing it. And also looking for self-identifying areas of improvement, like increasing positive social interaction. So a lot of things that people can maybe think about doing or modifying that will help them both to improve quality of life with pain and ultimately maybe reduce pain awareness entirely, reduce pain severity. All right, that's next, moving on. What can we do to help people?
Yeah, thank you, Kaitlin. As I hope you can all tell by this point in the presentation, pain is really complex. And so we know that there's not always a one-size-fits-all approach, but we wanted to talk a little bit more about some strategies that are typically helpful for a majority of the people that we work with. So these are more of those tangible skills that we can put into practice, no matter the setting that we see individuals. The first and probably one of the most important is working with your medical team. It's important to have individuals with persistent pain maintain regular contact with their primary care provider, and to remember to see the primary care provider on the good days and not just the really bad days. And one of the reasons why we talk about the importance of primary care is it's really easy to get lost in specialty care. And specialty care tends to be really siloed. We need someone at the center of that care team that can help the patient say, it's been 4 months since you've seen your neurologist for your migraines. Maybe we need to look at getting back into there, because with chronic pain, there are multiple factors that could be contributing to the experience of pain in the individual. And so we need to have a well-versed team of oftentimes specialists to help manage some of that. And so to prevent it from being siloed, we want the person in the middle to help kind of steer the individual to where they might need follow-up and regular care. Also, I really encourage patients to make notes and prepare for their appointments, because if it is a bad pain day, concentration, focus, and ability to kind of focus on task in those 15 to 20 minutes of a primary care or specialty care visit can be difficult. So keeping a tally of symptoms, keeping a prioritized list of what they want to talk about in the visit, knowing that they might have 10 things on that visit list, and they might be able to talk about 1 or 2 that day. That's why the regular contact with that primary care provider is important, so that we can make sure we get them off to the appropriate level of care for what might be going on. In addition to that, it's really easy as a patient to be frustrated with the medical system, but it's important to remember as a patient that your doctor is a human too. If they had the ability to solve everything in 1 or 2 15-minute visits, they would wave that magic wand and make it all go away. And so it's important to be honest and realistic about what you're able to do and what you are doing. And one thing that patients don't often do during those brief primary care or even specialty visits is talking about what they're doing for themselves outside of the visit. So those self-management activities. I personally feel it's important to bring those into the conversation with the provider, so they know that you're not just expecting them to fix this, and that you're actively engaged in the management of your overall care. And also for patients to know that they can feel confident in rejecting a treatment or deferring a treatment if they're not ready for it at that time. What I always kind of communicate to the patients that I'm working with, whether it's about yeah, there's a trauma history and they might need treatment for PTSD. Are they ready for it? And is it the appropriate time? Kind of reminding the individual that I'm working with, you're in charge, I just work here. We need to have a dialogue about this and not me prescribing treatment based on what could be going on in that moment. And Liz, I know you had some thoughts on kind of working with the medical teams, and would you feel comfortable kind of speaking to some of that?
Yeah, I know we're a little squished for time, so I was just going to hop in. So as we said at the beginning, I'm Dr. Paulson. I represent the medical team. So I think, this is a really difficult situation for a lot of people, and both for the medical teams and I would imagine for a lot of you that work in behavioral health. It's awesome to see how many people from all over there are, including Harborview, which is one of the places I work as an acute pain doctor and anesthesiologist. But I think that one of the things that comes up a lot is how to sort of communicate between the two. One of the things Eric and I have talked a lot about, and all of our behavioral health providers have talked a lot about, is how to help the providers understand that mental health or behavioral health is not sort of like a bucket that we put people in. So I think all of your tips here, Eric, for patients are wonderful, and some of them also apply from a behavioral health perspective in terms of supporting the patients in coming back to the provider and talking to them about what they really need or want in this moment. I think one of the ways that the behavioral health team can be really helpful to the provider and to the patient is to help really, especially in chronic pain, even though in sort of like longer acting acute pain situations after surgery or trauma, is really try and identify goals. So helping the patient think about what are the things that are important to them that they are not being able to do right now. And I think this is a place where often the providers and the patients get very overwhelmed because the providers come and they're like, well, I can't do it. The patient comes and says, I can't do anything. I can't, I can't sleep. I can't do any of my ADLs. I'm miserable and I just want you to fix it right now, which is very overwhelming for the providers, as well as leads the patient to end up feeling frustrated because the provider sort of reacts poorly often, and it's like I can't do that. So I think that can be very helpful. I try to always work with patients around what is like their short-term and long-term goals, because having no pain is not really often a realistic goal, and so it can help patients to really reframe like what it is that they want to do, or what is one or two things that they want to do, and work on how we can get to those without or with different options of treatment and medication. And I had the opportunity to look a little bit at the Q&A, and so one of the things I was going to say is that there was a few questions in there about there was someone who had a question about sort of diagnosis, surgery, thinking about like what is tissue damage versus what is pain versus, how does misunderstanding lead to tissue damage? And I think this idea about when to decide on the diagnosis of chronic pain is a really important point. And so I think, so one of my biggest fears always for my patients is that doctors are dismissive because they see the patient as just a chronic pain patient. So I do think it's important to help advocate for patients and within your practices for patients to really specify if they are having a new problem, what is different than prior. So, if they feel like things are different than they were prior, and this pain is somehow different than what's the ongoing pain or underlying pain, it's helpful to, really be specific about that. I think it's also helpful to support patients who are sometimes very frustrated in talking about like what the diagnosis might be, but also being open to the fact that I often tell my patients that regardless of the diagnosis, when something has gone on for more than 3 months, it doesn't really matter why. There's always a central sensitization component when our
And
body has been in pain for 3 months.
And Liz, that kind of leads us to the
Yeah.
common medical
Yeah.
treatments that we have, because we might not always have a discrete diagnosis or condition because it could be multiple factors, but the medications, the surgeries, the injections, active physical therapy approaches, whether it's acupuncture, TENS, or spinal cord stimulation sort of approach, behavioral health approaches, or complementary medicine, those are kind of the buckets of treatment that we tend to pull from. And I know a complete and exhaustive conversation of all of those is beyond what we can provide today. And so what we want to talk about is more what we can do. And I know you mentioned goal setting. Kaitlin, would you mind talking a little bit more about goal setting and kind of the idea of self-efficacy?
Yes. Okay. So in the interest of our waning time, I will be brief here, but I want to just recognize that goal pursuit is not just wanting to do something. It is a function of whether or not we value the outcome enough to work on it and whether or not we think we can do it. So self-efficacy is just as important as wanting the outcome when it comes to goal pursuit. We ask people to make a lot of changes when they're managing chronic pain, physical, emotional, health behavior changes, and it's overwhelming, I think, often for the patient to think, how am I going to do all this stuff? And we really want to focus on boosting self-efficacy, especially pain-related self-efficacy. Can I do the things I want to do even though I have pain? Can I overcome the barriers that I perceive in my course of life as, you know, as pain makes it more complicated? Can I cope with pain? Do I believe I can cope with pain? So that pain-related self-efficacy is associated with better functional outcomes, reduced emotional distress, reduced pain severity, so even the pain itself. And this is especially true for people who have had chronic pain the longest. So recognizing that self-efficacy is key. Next slide, please. So we want to use goal setting strategies that will help people to be more process oriented and less achievement oriented. Flexibility and goal pursuit is essential when dealing with chronic illness, certainly when dealing with chronic pain. And this is important because the way that pain or chronic illness impacts personal goals, identity, achievement, things like that can be a major source of pain-related distress. So use SMART goals. This is a tool that's meant to help us empower, build self-efficacy, and ultimately think about flexibility in the pursuit of goals and behavior change. Next slide, please. We also want to think about obstacles to goal pursuit, you know, recognizing that what stopped us before is likely to stop us again. So let's pay attention to both internal and external barriers, plan for challenges along the way. Don't expect, you know, change to be linear, and think about some of these things here down at the bottom that really we need to address when we're thinking about planning for and executing goals. And also, what are our personal goals? Like, what are we trying to achieve? What do we want to see change? Or, you know, if our treatment worked, what would be different about our life? How would we know it worked? So kind of thinking beyond just the reduction of pain itself, why would you want to reduce pain? How would that change your life? So kind of thinking more in functional and values related goal setting. Next slide, please.
And so what we tend to look at are common themes, is that people want to get out and they want to spend time with their kids, spend time with their family, be able to get back to work. And that's a process. And a lot of the times we start that process with kind of stretching and basic movement. This is not exercise. This is not necessarily physical therapy. This is taking a different approach to movement, because all of our muscles are basically like rubber bands. So if we take a rubber band and we stretch it and we hold it for a little bit, when we let it loose, it's a little bit bigger than it was before. And that's the case with our major muscle groups as well. When we engage in that gentle stretching, that loosens up that muscle. That increases flexibility, range of motion of the joint, increases blood supply and to the muscular skeletal system, and also protects against future injury. And know that our stretching activities also decrease the inflammation. They're anti-inflammatory in nature. I feel like I just had a Porky Pig moment there. I apologize. And so what we want to do is to kind of gradually work towards that goal that the American Council on Exercise talks about, and working up to stretching about 30 minutes a day, 3 times a week for that flexibility, because that creates the foundation for additional movement and to kind of break that larger goal that Kaitlin was talking about into smaller sections. Because when we're looking at the chronic pain cycle, a lot of people get caught in this process where they have chronic pain, but life happens and they need to go do something. And so after they go out and do something, they have an increase in overall pain. And then that leads to a feeling of need for rest and recovery and decreased activity, which leads to the negative emotions and frustration that we all have when we're not able to do what we want to do, which can then lead to avoidance and withdrawal because we don't want to feel those negative emotions, which then increases our overall sense of disability and disease. And so we need to be careful how we help people out of this process, because we'll get caught in kind of that boom and bust cycle, or we'll go out and do something, we'll pay for it for a few days, and then we'll go out and do something and we'll pay for it a few days. And with that, we end up doing less and less over time. And so we need to think about how we can reverse that cycle. And one of the ways that we talk about it is through kind of activity pacing to kind of increase that gradual momentum. And so to take more of a scientific approach to pacing activity. So if I'm doing something like standing, let's say I can stand for 10 minutes on the first day, maybe 11 on the second, and maybe 9 on the third. We'll average those together and get 9 minutes or 10 minutes. I'm bad at math. And so instead of starting with that 10-minute goal, we want to start low. We want to start at 80% effort. So to start with standing daily for 8 minutes, because then it helps teach us what Kaitlin was talking through pain neuroscience education, that we can do that activity safely and we don't need to alert with the same amount of pain. And then we can look at kind of gradually increasing that by 10% or so every week or every 2 weeks based on the progression to kind of get out of that physical deconditioning and chronic pain cycle. And so, Kaitlin.
So mindfulness-based interventions have good evidence in chronic pain management. And so most common known as mindfulness-based stress reduction, but ultimately I see mindfulness as having incredible utility in building insight into how chronic pain influences us, as well as what factors influence our experience of chronic pain. And I find that we use mindfulness kind of across the board with all kinds of different therapies, whether they're mindful focused or not. So for example, classic cognitive behavioral therapy, you still need to be able to notice your thoughts and your emotions and what happened that kind of brought on that change. And so that mindful awareness of self, the non-judgmental awareness of what we're experiencing, is key to a lot of therapy techniques and is in and of itself a tool for management of chronic pain. Next slide, please. We often miss true mindfulness when we are talking about mindfulness with the people we work with. So remembering that meditation is only one way to practice mindfulness, that mindfulness practice is a much larger skill, moving beyond just a meditation session and into the way we're experiencing our moment-to-moment life and the way that we notice what we feel and things like that. We are really truly out of time, so I'm not going to go over these different factors or 7 attitudinal factors of mindfulness or give more of the history of mindfulness. But it's something that you can find easily out there. I encourage people who are interested to take an MBSR class yourself. You'll be better at teaching mindfulness if you learn it that way. Read Full Catastrophe Living if you like to read. That's one of our foundational texts for mindfulness work. And understand these 7 factors of mindfulness, because it is ultimately the most helpful if we take it, beyond a, sort of prescribed medication session and into maybe perhaps an attitude that we approach life and stress with in general. Next slide, please. We see changes in cognitive and affective systems in frequent mindfulness practitioners, and changes in things like the default mode network that can result in sort of reduced distress overall, reduced distress associated with pain itself, and changes in brain networks that are, correspond with those changes in reduced distress associated with pain and various things. Mindfulness also is associated with reduced pain severity itself when people are practicing frequently and continuously over time. So it's something that might not change somebody's experience immediately, but I encourage people to keep practicing it, because what you might notice is a couple months down the road, if you've been practicing mindfulness consistently, that your emotional reaction to pain is much more neutral, perhaps less distressed, and that you feel like you're just a little bit more able to deal with it as it comes up. And next slide.
And so we're rushing through this because time is a reality that we need to exist in. Kaitlin already mentioned that pain is bidirectional as far as pain is concerned. When we're not sleeping, We have more pain. When we are sleeping, we have less pain. We have empirically shown this through some of our own data here at the Center for Pain Relief. What we frequently talk about when we talk about improving sleep is we talk about sleep hygiene. Those are the common do's and don'ts with kind of sleep. You know, get regular on your hours, only sleep when sleepy. Don't spend time in bed unless you're engaged in sleep or sex. Try and get up again if you can't fall asleep after 10, 15 minutes. Avoid caffeine, alcohol, nicotine. Don't nap. Engage in healthy sleep rituals before you go to bed. Engage in exercise and diet changes that support healthy sleep. Both quiet your mind and get to sleep, and also CBTI coach are great tools for psychoeducation for patients around improving sleep. However, sleep hygiene, I tend to view that similar to how we're brushing our teeth on a regular basis, is that that's our daily maintenance to keep sleep regular and healthy. However, with chronic pain, we see that 40% of people have insomnia that is related to a chronic health condition. And so just brushing our teeth and kind of that example of, you know, trying to maintain good dental habits is not going to be helpful if you have a cavity. And so sometimes we need to do something different in that situation. And that typically means cognitive behavioral therapy for insomnia. This can be used individually in a group modality. It's highly effective, especially with individuals with chronic pain. Is that they see that between 70 to 80% of people within this analysis had an improvement in overall sleep after going through a short course of CBTI. And then at follow-up, they also saw that about 60% had a decrease in overall pain. With those odds and those percentages, I'm not a gambling man, but that is a bet I would take. And so I would encourage providers to look into how they might be able to expand their cognitive behavioral therapy for insomnia skills, if that's through someone like Deployment Psych, who offers periodic free training.
All right, unhelpful thoughts here. We're talking about this cognitive appraisal process, recognizing that what we think about something and how we feel about something has a huge influence on how much attention we pay to it. And it's part of our learning mechanism that can increase our attention to pain or potentially reduce our attention to pain. And so the way we think about something is an indicator of danger just as much as some of these other sensory factors are. Next slide, please. So you think about this attention, interpretation, and behavior process and how this can either influence us to perhaps be more vigilant to something, more worried about it, more fearful, or the other way, perhaps reduce our attention to it, make us think about it less, make us worry about it less. So you notice something, like you bend over, you have a pain increase. If somebody has not gone through some of this education, they might think something is wrong, something is broken, now I will get worse. They're going to have an autonomic sympathetic stress response that's going to reinforce, yes, I'm in danger, yes, this is serious, yes, pay attention to it. And the behavior that follows is likely to include activity avoidance, increased distress associated with what's going on, attention to symptoms, and potentially loss of function over time. Next slide. Whereas if somebody has had some education related to pain neuroscience, the same thing might happen, but they might have a different interpretation process. They might say, I know bending is safe. I know that this is just a sensory experience and hurt does not equal harm, and I have strategies to manage this. They're still likely to have an initial physical stress response because that's instinctual in response to pain, but they're going to recognize what it is because they've been practicing that mindful awareness of self. They're going to be able to self-soothe it and ultimately send that signal that they're safe based on that self-soothing of the body, because you can't relax and fight a tiger at the same time. So if you can make yourself relax, your nervous system will think you're not fighting a tiger. So we can use that here to help, change that learning process. Behavior is ultimately going to reflect this different interpretation process. That person may use pain management strategies, ultimately feel less stressed out, even if they do have to rest, because they'll be resting with confidence versus resting with fear. Pain has a major impact on social relationships. And so we want to think about, how people respond to their social interactions when they're in pain. People tend to withdraw. We often exhibit pain behaviors. We'll talk a lot about our pain. We'll lose interest in kind of interacting with other people. We can't do the same things that we used to do or that other people are doing. All of these different elements are associated with increases in pain severity or pain functional impact over time. So you want to think about the ways that these things ultimately backfire and lead to, worsening pain related issues. Let's go ahead and go to the next slide. And so we want to think about, pleasant social interaction and broadening people's kind of a field of social awareness, perhaps, so that we are including more of this empathy, more of this positive social interaction. Ultimately, that is going to reduce attention to pain and potentially reduce the functional impact of pain. You also want to consider, if you are a person who lives with or cares for a person who has chronic pain, that we don't want to be over accommodating or under accommodating when it comes to their needs around pain. If we over accommodate or we make decisions about what somebody can or should do, then we're taking their agency away. And ultimately that can lead to, worsening functional impairment and mental health symptoms that are not helpful. On the other side, if people ignore their pain, then they feel ignored, they feel isolated, invalidated. And again, resentment and difficult emotional experiences are associated with it. So we want to find a middle ground where we are empowering people to feel like they can cope with and manage their pain, while at the same time showing them empathy and being helpful in the areas that they need. Next slide.
So key takeaways, despite the fact that we have not followed our timetable and schedule, we hope that you're able to take away from this some education about chronic pain that helps reduce distress, improve function, and improve pain efficacy. We want to make sure that people develop and maintain, and maintenance of chronic pain is multifactorial and necessitates a multidisciplinary and collaborative approach to treat, because effective management of chronic pain requires active participation of the patient, and it takes a lot of motivation and support from our part to get that from someone who's in significant distress. And that there are also many factors that influence the impact of chronic pain and many strategies for management. Considering that, we do have a learning community coming up in later this summer. It is just open to people in our region, so Washington, Oregon, Alaska, and Idaho, if I'm getting that correct. It will be meeting on July 12th, July 26th, August 9th, and August 30th. The link there will help take you to that. Kaitlin, you can also talk about TelePain, which is another resource for Washington and Alaska for us.
Yeah, just letting people know about this. This is a free weekly conference that includes didactic presentation, so information about various aspects of pain management, treatment, and the practice of pain medicine. We offer case consultation, so people can come in with a difficult case and receive advice from an expert panel on pain management. We also have an opioid hotline, which again is, mostly for people who are in Washington or Alaska, but it is a really wonderful resource that will help if prescribers have questions about opioid prescribing, tapering, management of opioid prescription in the presence of a substance use disorder, all kinds of things. We have really wonderful experts answering that phone line that can be helpful to people.
Additionally, we wanted to point you towards some other books that we find helpful. This is not an exhaustive list. I've got many more on my shelf that I would add, but space and everything is a premium. We just want to point you in the right direction of a few that we really do feel supportive of. In addition, there are some really good apps for mobile phones. Probably Kaitlin and I think Bethany recommend Curable the most out of these three. If as a provider you want to, you can get the ability to share a free 6-week trial with the patients that you are working with. In addition to that, there are some really good online resources available. And we wanted to point you to some additional videos that are appropriate to be shared with consumers. I know that we share these very frequently, and it opens up a good conversation to looking at pain differently. And with 3 minutes left, we'll say thank you. And I don't know if we have time to answer a question. I apologize for that. I know we really wanted to.
I can just address the THC and CBD, which it looks like a couple people asked. So the data on THC and CBD is very hard to interpret. There's more and more data as we have more and more sort of options for research. So I think it'll continue to be an evolving field. What I usually tell my patients, like from a clinical practicality standpoint, is, if you live in a state where those things are legal, it is reasonable to try them and see if they're helpful for you. It's not something that, so the quality control among different groups or among different things that are sold essentially is somewhat mixed. And so it's difficult to sort of interpret like what you're getting. And I generally think like if it's helpful for people, that's great. And if not, then I wouldn't do it. If it causes you to feel altered, I give people similar warnings as I would about other medications for tripping, like feeling altered and falling, and basically say, honestly, the people at the stores that sell it are much more knowledgeable than I am, because there's not consistency in the product and there's not consistent research on medical grade marijuana in the like federally funded literature, because it's federally legal. And then I always just remind people, like, please don't take it across state lines or take it on an airplane, because even though you may feel comfortable, it can have pretty significant legal consequences for you.
One thing just to add to that I do caution people about is that we want to make sure that you're not using this as a form of avoidance. So it's not keeping you from doing the other things. I'll stop there.
Thank you all so much for being here. And yes, I agree with the chat is just going off, saying thank you so much for being here. This was great. This could definitely be all day, and they want to replicate you guys, put you everywhere. So thank you so much. I'm really glad we had you here to present. Please do take our survey. It really helps us to know what we're doing right, what we could be doing better. We appreciate it. Sorry if we didn't get to some of the questions, but you all gave us a lot of great resources in the slides, so everybody will be getting those. Please look at the resources in the slides. We'll also try and list some additional resources that were listed on an additional resource page. But it is noon and we are out of time. And we want to thank you all so much for being here, taking time out of your day just to learn more about this important topic. So thank you so much.